What are the key benefits of medical testosterone therapy? Now, before I answer this question, I want to just point out and emphasize the word key and the word medical. This is not going to be a discussion on all the potential benefits of medical testosterone therapy. This is also not going to be a discussion on the potential benefits or drawbacks or risks of non-medical testosterone therapy. So, unlike what you've heard from various people on social media, and I'm going to try to be as civil as I can, but unlike what they've told you, when you are talking about medical testosterone therapy, using it for medical purposes, legitimate medical purposes, what is the goal of therapy in 90% of men? Is the goal of therapy to make you quote unquote feel better or have more energy? The answer is no, it is not. No, that is not one of the key benefits, actually, believe it or not. Because, simply put, how you feel is extraordinarily subjective. It means different things to different people. And when it comes to measuring clinical endpoints, it's very hard to do that with something as ephemeral and subjective as feel. Are one of the benefits of medical TRT to improve your sex drive and libido? Is that one of the primary, or what I'm calling key benefits? The answer is no, it is not. No, it's not. You heard that. Let me say that again. Are one of the key benefits of medical testosterone therapy to increase your sex drive? Answer, no. Why? Because sex drive, believe it or not, is a very complex psychological epiphenomena. It has far more to do. It encompasses more than just your testosterone levels. And actually, unlike you've been told, estradiol actually plays a much bigger role in libido than does testosterone. That's a separate subject, and that will be one of the key questions I answer in one of these videos as well. So if the goal of medical TRT is not to make you quote unquote feel better, and it's not to increase your sex drive, then what is the primary goal? And that's not to say that TRT can't do those two things, by the way. I'm not saying it doesn't make most men feel better, whatever that means. What I'm saying is, when you're a physician and you take somebody and you try to determine should this person be on testosterone or not, 90% of the time, the primary endpoint you're looking at is not how they feel. All right, so what are the key benefits? What are the key goals? Well, the key goal of medical testosterone therapy in the vast majority of men is body recomposition. It's to reduce their visceral and subcutaneous fat, especially their visceral fat. I'll get into explaining the difference between the two. And to increase their skeletal muscle mass. And then also potentially increase their bone density. So, increase muscle mass, decrease fat mass, increase bone density. Those are the key benefits of medical testosterone therapy. No, they are not the only benefits. No, they are not the only things that we look at and pay attention to. Yes, you can get those things from non-medical testosterone therapy. I'm not making any of those points. The point I'm making is, for the vast majority of men put on testosterone at your average TRT clinic, the endpoint goal of putting that man on testosterone is to increase their skeletal muscle mass, reduce their fat mass, especially their visceral fat mass, and increase bone density maybe. That's the key benefit. That is the key goal. That is the most important thing that tells you whether or not the therapy is working. So now, why do I say that? The reason I say that is because by increasing skeletal muscle mass and reducing visceral fat, you improve their metabolic profile, number one. Okay? If they're diabetic or pre-diabetic, by having increased muscle mass and reduced visceral fat, you will improve those things. You will greatly improve those things. And not only will you greatly improve their just overall metabolic state, you'll greatly improve their overall inflammatory state and their chronic disease burden. So testosterone, by increasing muscle mass and reducing visceral fat mass, can greatly lower your burden of most Neolithic chronic disease states. Improving your sex drive does not necessarily improve your chronic disease burden. Making you less depressed also doesn't necessarily improve your chronic disease burden. But having less visceral fat and having more skeletal muscle mass, especially if before you start treatment you have low skeletal muscle mass and you have very high subcutaneous and visceral fat mass, that's sometimes referred to as a condition called sarcopenic obesity. Reversing that will greatly improve just about every chronic disease that person has. So that is the endpoint that you're looking for with testosterone. Not only does it improve your chronic disease burden and your overall metabolic profile, it also directly counteracts the inflammatory process of aging. Yes, it does. Yes, it absolutely does. Because what happens when you age? When you age, you lose skeletal muscle, and you lose the quality of the skeletal muscle you have. You get fat deposition inside your muscle, so the quality of your muscle goes down. And there's all kinds of studies showing that muscle mass, actually it's muscle strength more so than muscle mass, is highly correlated with longevity. So testosterone directly counteracts the inflammatory effects of aging on skeletal muscle and on fat. What happens as you age? You develop more subcutaneous and, worse than that, visceral fat. Visceral fat is the fat that surrounds your internal organs. It's not the pinchable fat that you can see. It's not the fat that you can remove with liposuction and tummy tucks. That's sub-Q fat. Subcutaneous fat, believe it or not, has protective properties. What we're primarily concerned with is the visceral fat. We want to reduce the fat around your internal organs. Why? Because that's the fat that secretes all kinds of inflammatory cytokines into your circulation. And actually what they do, it secretes what are called inflammatory adipose cytokines directly into the portal circulation of the liver. So having a lot of visceral fat is very, very bad for you. It increases your risk for all kinds of chronic diseases. So again, that's the main goal and the key benefit of testosterone therapy. is that it increases your skeletal muscle mass, which improves your metabolism, improves your insulin sensitivity, improves your peripheral glucose utilization, and probably directly increases your longevity by increasing the quality of your muscle and your muscle strength. And it reduces visceral fat, which is the inflammatory fat that surrounds your internal organs. Another thing that aging does, it also decreases your bone density. And bone density is also highly predictive of shortened lifespan, decreased bone density. I'll talk about bone density at the end because it's actually a little bit controversial. It's not that testosterone, it definitely does increase your bone density, but as far as does that decrease your risk of fractures, etc., is an area of controversy, which I'll talk about. So, reducing visceral fat. How does testosterone reduce visceral fat? Well, first of all, what other drugs reduce visceral fat? Not many. Very few things reduce visceral fat. Some of the diabetes drugs have been shown to reduce visceral fat, especially these new GLP-1 drugs reduce visceral fat, or seem to. Statins may reduce visceral fat. Growth hormone reduces visceral fat in patients with profound growth hormone deficiency. Non-medical HGH use does not reduce, I mean, it may reduce visceral fat, but it has other negative issues associated with it. So very few things actually reduce visceral fat. Testosterone does reduce visceral fat, and that was shown in a paper in 2016 in a journal called BMC Medicine. So, but how does it do that? Well, the reason why testosterone reduces your visceral fat, and a lot of you won't like this, but that's tough that you don't like it, is actually it increases your estradiol levels. And it's the estradiol that reduces your visceral fat mass. It's not directly testosterone that does that. So, if a key benefit of medical TRT is that it reduces your visceral fat, and the way that TRT reduces your visceral fat is by increasing your serum estradiol levels, now you can start to understand the reason why drugs that prevent the conversion of testosterone to estradiol are not a good idea to take. So let me say that all again, because I know people don't listen, and studies show that you often have to hear things 3 times before you are able to solidify and internalize it. Testosterone therapy is one of the few things that has been shown to reduce visceral fat. Visceral fat reduces your longevity, increases your risk for just about every chronic disease you can think of that isn't a purely genetic disease. The way that testosterone therapy reduces visceral fat is by increasing your serum estradiol levels. So the higher your estradiol levels are as a result of testosterone therapy, the lower your visceral fat will be. And that is why preventing testosterone from converting to its extremely crucial secondary metabolite called estradiol is harmful, and why guys who take aromatase inhibitors do not get a visceral fat reducing benefit, or if they do not get as much of a benefit as they otherwise would had they not taken the toxic life-shortening aromatase inhibitor drug. And there are other problems with aromatase inhibitors that I will cover in a separate comprehensive video when I answer the question about so-called estrogen management. People that use the term estrogen management don't know what they're talking about. Period, end of story. In the context of testosterone therapy, talking about estrogen management is for someone who's uneducated and doesn't know what they're talking about. You should not listen to those people at all. Because what they're saying when they use that term is that they don't understand how testosterone actually works. They're advertising the fact that they have no idea how testosterone works. So that's visceral fat. Muscle mass, muscle strength. Does testosterone directly improve muscle mass? The answer is yes, it absolutely does. Has that been shown in multiple studies? Yes, it has been. It increases muscle mass in a dose-dependent manner. What does dose-dependent manner mean? It means the higher the dose you use, the more muscle hypertrophy you get. And as far as the studies that exist now, we've never really studied the muscle or the anabolic effects of testosterone in healthy subjects beyond a dose of 600 milligrams a week. So the ceiling may be much higher. Does that mean you should use higher than that dose or even as high as that dose? No, you should not. But it's just simply a fact that testosterone has a dose-dependent anabolic effect, the ceiling of which we do not know at this particular point in time. I already alluded to the reason why muscle mass is important for longevity, but really it's muscle strength that's important, not necessarily your overall muscle mass. But how does testosterone increase muscle mass and therefore muscle strength? Because testosterone shifts the balance. You have a balance in your body between how much protein you break down and how much protein you synthesize. So you actually break down muscle all the time to use for energy. And then there's also the separate side where you're constantly synthesizing new muscle. What testosterone does is it shifts the balance towards muscle protein synthesis. That's what it does even at low doses, even at so-called non-superphysiologic doses. At testosterone doses that bring your total testosterone levels above the upper limit of the normal range, testosterone has additional muscle building effects. It has what's called a stem cell effect. So it takes precursor cells and creates new muscle cells at supraphysiologic doses. Yes, it does. Yes, it does. So at lower doses, it shifts the balance between protein breakdown more towards protein synthesis. At higher doses, you get a stem cell effect and you create new muscle from what are called satellite cells. That's how testosterone works. And that's also the reason, and this is going to be controversial, why it's not simply you get on testosterone and you just go to the middle of the normal range. No, most men need significantly higher than the middle of the normal range to get adequate body recomposition effects, and that's just a fact. That's just a fact. Does that come with risks? It probably does come with risks. Because we don't know what the especially long-term risks of having above normal range testosterone levels are. Nobody knows that. Never been a study that's been done long-term. What we do know is that in a lot of the trials, particularly the ones that looked at patients with diabetes, that it showed a positive, where testosterone showed a positive effect at preventing and reverting newly diagnosed diabetes. A lot of those men did have supraphysiologic testosterone levels for at least part of the dosing interval. Their trough levels may have been within the normal range, but just knowing how testosterone works pharmacokinetically, all the patients the vast majority of patients that experienced a significant effect and had their muscle mass increase while their fat mass either stayed the same or went down, most of those patients were above the so-called normal range for a significant duration of the dosing interval. And studies that used doses of testosterone, particularly in a gel form, that kept men below the upper limit of the normal range, mostly did not show a beneficial effect on any of the metabolic parameters that matter long term. And have I shown charts of those studies where I pointed that out? Yes, I have. So to get a positive metabolic effect, aka to get a greater anabolic effect and a greater visceral and subcutaneous fat reducing effect, you often need two things that you do not hear about from people that don't know what they're talking about. The two things you need, number one, is usually for at least part of the dosing interval, you need to have levels that are above the upper limit of the normal range. And I will debate anybody on that subject. I will not debate uneducated people or your favorite bodybuilding coach who doesn't even have has no education, but I will debate other doctors and researchers on that point. Absolutely, I will. Because the research backs up exactly what I said. Most men who need a positive body recomposition effect from testosterone, they cannot simply go from 200 to 500. That will not work. That's not to say that you just blast people with 800 milligrams of testosterone a week. No, you do not do that. TRT doses of testosterone medically are 300 milligrams a week and under, and very, very few people need 300 milligrams. The second thing that you need, that you especially have not heard about on YouTube and from all these people that you should absolutely stop listening to, is you need an estradiol effect. The studies, particularly in diabetic patients, show that when you don't get a positive beneficial effect, glycemic-wise from testosterone, and what is the common denominator in most of those studies? Low testosterone levels and no estradiol effect. So you need your estradiol level to go up. But you need a good, decent dose, and you need an estradiol effect. You need your estradiol level to go up. And I will delve into great detail on that when I answer the estrogen management question, which I will do in a separate stream. Okay, third thing that testosterone does. It increases bone mineral density. Testosterone has direct effects to increase bone density because it stimulates what are called osteoblasts. Those are the cells that lay down the bone matrix. And it also inhibits osteoclasts. Those are the cells that, break down the bone matrix. Part of the testosterone effect at increasing bone density is also through estradiol as well. So estradiol in women especially has a very well-known effect at increasing bone density. And in fact, before, in the 1950s and 60s, doctors used to use testosterone to treat osteoporosis, including in women. Okay? So the fat reducing and especially visceral fat reducing effects of testosterone come from estradiol. The anabolic effects or skeletal muscle mass building effects of testosterone come directly from testosterone. They don't come from DHT. DHT does not play a role in the anabolic effects of testosterone at all. DHT is actually enzymatically inactivated in skeletal muscle. Oh, that's not what I heard from my favorite bodybuilding coach, or that's not what I heard from my favorite YouTube influencer. Well, your favorite YouTube influencer is wrong. The anabolic effects of testosterone come from testosterone. The bone density increasing effects of testosterone come from both testosterone and estradiol. So fat reduction is an estradiol effect, especially visceral fat reduction. Muscle building effect, testosterone directly. Bone density increasing effect is a testosterone and estradiol effect. Now, as far as bone density goes, bone density is very important because obviously as you get older and you become more frail and you lose bone density, you develop osteopenia, and eventually you develop osteoporosis, you're at risk for fractures. Okay? Although testosterone has been shown to increase cortical bone density, unfortunately in the studies that exist today, the testosterone-induced increase in bone density has not translated to a reduction in fracture risk, unfortunately, in the studies that have been done so far. So I just say that for full transparency, that although testosterone does increase bone density, it has not been shown in any high-quality study to reduce the risk of fractures. And in fact, in one study published this year in the New England Journal of Medicine, testosterone was shown to actually slightly increase the risk of fractures. And the reason why I think that is because in that particular study, they were actually looking at the results of another study which used low-dose testosterone gel. What do we know about low-dose gels? You don't get high levels of testosterone, and you really don't get a very good estradiol effect. So I think if they do longer-term studies with injectable testosterone or even pellets, and they get a good estradiol effect, I think you will find a greater bone density benefit and a fracture risk reducing benefit. That's what I believe. But do I have evidence for that right at this very second? The answer is no, I do not. No, I don't. So those are the key medical benefits of testosterone therapy. And that is why I say all the time that if you go to a TRT clinic and they do not measure your body composition, get away from that clinic. That clinic does not know what they're doing. Because the way that testosterone gives you all the medical benefits, okay, not necessarily the aesthetic benefits, not necessarily the mostly nocebo, I feel so much better, I have more energy benefits, which it may do. That is a real effect of testosterone. But those are the two things that most TRT clinics are concerned about, are what are your levels and how do you feel? Nope, that's not evidence-based. That ignores the key thing that you should be looking at, which is body composition. Your skeletal muscle mass should be going up. Your fat mass should be going down. And after a year on testosterone therapy with no aromatase inhibitors, you should start to see visceral fat mass going down as well. And as your visceral fat mass goes down, your glycemic control, your hemoglobin A1C, your blood glucose, your bad cholesterol, your LDL cholesterol should go down. In fact, your LDL cholesterol should go down after a year on testosterone, also primarily from estradiol, because estradiol lowers bad cholesterol, LDL cholesterol. It doesn't lower it to an astronomical degree. No, estradiol is not a substitute for statins if you need statin medications. That's not what I'm saying at all whatsoever. But it is a fact that estradiol, including estradiol that you get as a result of testosterone therapy, does lower your bad cholesterol.